Our technical prowess, I suppose, doesn't sound that remarkable, but the outcome of what we do truly is. And behind every successful redesign, new pathway, clinical innovation, finance is at the heart of it. So be really, really proud of what you do and what you achieve. And remember, what you do connects through not just to the front line, but to individual families and friends and people out there.
That was Elizabeth Omani, Chief Financial Officer at NHS England and Interim Director General of Finance at the Department of Health and Social Care, speaking on the final day of the HFMA annual conference. Welcome to HFMA Talk, the podcast for NHS Finance. I'm Alex Hunt, and today we're bringing you the final episode in our 3-part mini-series covering highlights from the annual conference. You'll hear more from Elizabeth Omani's session on priorities for the future throughout this episode, as I discuss the key themes with Steve Brown, editor of the Healthcare Finance magazine. Let's get into that conversation. We've heard a lot about planned changes to the NHS, with shifts from hospital to community, treatment to prevention, and analogue to digital. But how will the financial framework have to change to support this? What has the government said to date, and did we learn anything new from the HFMA annual conference back in December?
Hi, Alex. That's a good question, and you're right. The way the money works and flows through the system will need to change a lot to help deliver the government's ambitions. We're already starting to see some of those changes, but there's lots more to come. And Elizabeth Omani, the Chief Financial Officer at NHS England and Interim Director General for Finance at the Department of Health and Social Care, did give a few snippets of insight into this when she addressed the conference on its final day.
When Jim asked me to step across into this role, a lot of people in this room, really good close friends and colleagues, said to me, do you want to really do this at this particular time? It's never been more difficult. It's never been tougher, not just from a finance perspective, but public dissatisfaction was at its highest levels. We had waiting times climbing, record levels, demand rising, industrial unrest. We've still got that. And to be quite frank, we started this financial year without a plan, or at least a plan that we could afford.
She was quite clear. NHS finance must fundamentally be aligned to the ambitions of the 10-year plan and the 3 shifts, adding that there is lots going on in terms of financial strategy. By the time she spoke to conference, the NHS already had the planning guidance. That's 2 years of allocations, the revenue and contracting guidance, the proposals for the payment system or tariff in 26-27. In fact, everything but the 3rd year of allocations to marry up with the 3-year finance settlement in last summer's spending review and the finance business rules. Those extra bits of guidance followed shortly after. But having the planning guidance broadly out before the HFMA conference itself marks a step forward. In recent years, the finance community has come to realise that promises of before Christmas literally mean Christmas Eve. Earlier guidance is a really good thing. It's hard to plan seriously if you don't know your specific requirements for service delivery, the system allocation, how prices will change to take account of cost uplifts and efficiency requirements, or the finance rules that will be in place. So getting the guidance out, even just a few weeks earlier, is a real positive and will hopefully help avoid a situation where finance plans remain unconfirmed months into the new financial year. The overall challenge still remains massive.
We moved from a £6.6 billion projected deficit to a balanced plan. People will say, yeah, but was that a work of fiction? And I didn't know myself at the time. We were triangulating it, trying to understand what the hell was going on, to be honest. We were moving at such pace. I think it happened in total over about a 7-week period. There were some particular systems that were really challenging. We spoke to them, we worked with them, we worked out where the productivity improvements could be made, where there were capacity gaps, how could we support them to deliver the plans. And it's true to say a plan's was submitted. We know it's backloaded. It's always backloaded. But from where I'm standing, and I was at the board yesterday, as I say, talking about month 6 numbers, because I was the paper, but I'm pleased to say at month 7, we're almost there. We've got a balanced position year to date, more or less. There's going to be some bumps in the road, no surprises there. But as you'd expect, looking through the numbers, agency headcount down 50%. Everyone's saying, yeah, but did we just transfer it across into bank? Bank spend down, bank headcount down 10%. Year on year, that's £1 billion we've saved in the first 7 months of the year, more than we delivered last year. There's a lot of stats and there's a lot of indicators suggesting to us that the run rate is still going in the right direction.
The service is being asked to do a huge amount. Reduce hospital waits while investing in out-of-hospital services, invest more in prevention, eliminate underlying deficits and ramp up productivity, all from comparatively modest increases compared with historic growth and limited capital budget.
So when Elizabeth Omani talks about fundamental alignment, what does she mean exactly?
Yeah, okay. Let's go back to the 10-year plan and take a look at what the government said it wanted to do in terms of NHS finances. First, it made commitments to bend the cost curve and deliver financial sustainability and to restore rigorous financial discipline. Well, some of this is just the age-old requirement to deliver greater efficiency, but the government has certainly upped the stakes, setting the NHS a target of achieving 2% year-on-year productivity gains. There's been a big focus on productivity since the pandemic, as it had a huge negative impact on what the NHS could deliver while facing dramatic restrictions on how it delivered services. That 2% productivity challenge is about double the pre-COVID level of improvement. So it's a big ask. And even if the NHS achieves it, it will still take until the end of this Parliament to get back to pre-COVID levels of productivity. Anyway, there are some reasons to be optimistic, as under some measures, in particular those calculated by NHS England, the NHS is currently exceeding this rate of improvement, particularly in the acute sector.
Delivery for me is helping build confidence. So when I stepped into this role, as I say, working very closely with political colleagues, with the Treasury, with Number 10, confidence was low about the NHS. No matter how much money we give you, it just disappears and nothing improves. Those types of comments, it's quite distressing, but actually I kind of knew it was true. We did seem to have this kind of hole in the bottom of the bucket that we couldn't quite close. But thankfully, building new relationships, new confidence, getting to a place where that plan, whilst heroic at the start of the year and we had to build it during the year, it actually, as I say, the new confidence has been built. And in the spending review, the NHS was one of the winners.
What does the government mean when it talks about restoring financial discipline?
Well, that's a difficult one. Primarily, they're concerned about the growth in deficit. 31 of the 42 integrated care boards in England needed deficit support funding to be able to submit a plan that balanced at the start of this year. That was some 2.2 billion in total. And these plans still relied on often unprecedented levels of savings. But does that result from poor financial discipline? There's a good argument that funding has simply not been sufficient to meet all the demands placed on the NHS. However, there probably is some substance to the suggestion that the NHS lost a little financial control during the pandemic. A temporary financial framework attempted to ensure that finances did not provide extra obstacles to meeting the significant and urgent extra clinical demands put on the service. And while extra funds were made available to cover additional costs, subsequent spending has not always reduced as the specific COVID demands have fallen away. The 10-year plan rather bluntly accuses the NHS of having developed an addiction to deficits, with deficits now widespread and an accepted feature of health service management. Worse, it says that the centre has reinforced this by rewarding organisations in deficit with additional funding. There's a lot to unpack here. For example, some deficits are clearly the result of historic underfunding. The NHS allocation formula aims to divide out resources fairly among different areas, taking account of the age and gender mix of different populations, levels of morbidity, deprivation, and even the unavoidable costs of providing services in different areas. But in fact, it only sets this as a target, and integrated care boards and clinical commissioning groups, primary care trusts and health authorities before them have been being moved towards target over a period of quite literally decades. Areas target allocations change over time as populations change and their needs evolve, but there have also been more major changes as the formula has been refined. And then on top of these changes, the department each year takes a decision over how much it wants to move under and over target areas towards their actual target allocation. It's really easy to go down a rabbit hole on allocations and the different arguments for moving boards to their target allocation slowly to avoid destabilisation or more quickly. A pace of change that is set in what is known as the convergence policy. But the point is that some deficits exist in areas that have been historically underfunded relative to their fair share of resources. So can they really be blamed for those deficits? At the same time, there are under-target areas that have delivered financial balance and areas that have significant deficits even though they're over-target in terms of funding, meaning they have an even bigger challenge in delivering sustainability. As I say, big rabbit holes here. But the government has made it clear that it wants much greater transparency about where financial problems lie. And to do this, it's committed to moving to target allocations, or at least setting a goal for arriving at fair shares, and stopping the practice of providing funding to support deficits. We've subsequently understood that this convergence is likely to take 3 years for most organisations, and perhaps as much as 5 for the more extreme outliers. Make no mistake, this is a big deal for some areas. The starting position for ICBs before the 26-27 allocations are core allocations ranging from 3.9% under target to 4.4% over target, although most boards are within 2.5% of target, which is basically considered as close enough. In the big numbers game that is the NHS, these small percentages under and over target mean some boards are hundreds of millions of pounds away from their actual fair share of resources for core services. And even to get within the 2.5% margin of their target would mean adding or losing tens of millions. We've operated a pace of change for a long time, but the difference now is that a timescale has effectively been set for achieving fair shares. There are some big challenges ahead in realising that, especially for those most over target areas.
So those that have been below target, they want to go faster. Those that are over target, they want to go slower. And half of you are just saying, can I just keep my feet on the ground? So it's been fascinating, the type of conversation, because the transparency is there. Now we want everybody to work in partnership, but now you can all see each other's numbers. You can see under and over target. Of course, there's a pace of change that needs to be, we've got to be sensible about how fast that can go. But people can start to see, in all honesty, there are difficult decisions that are being made in pockets across the country, and there are other places that haven't had to face the same choices. We've got to get to a place where there is a consistency around what people are asked to do in a national health service, and also, hopefully, a transparent way forward.
You mentioned deficit support a short while ago. What's that about?
Well, that's another distorting factor in understanding NHS finances. While the NHS tends to break even each year overall, this does not mean that all bodies or even all systems deliver break even. All 42 systems managed to draft a plan that forecast a break even position at the system level for 25-26. But this relied on some £2.2 billion of deficit support funding from the centre. As part of its tightening of controls, from this year the government has made this funding dependent on delivering against agreed financial plans, which basically require all systems to break even after allowing for that deficit support. If a board veers away from this agreed financial plan, it now loses access to that deficit support in year, compounding its deficit position and with consequences for future support. And on top of this, the service has been given notice that deficit support funding will be withdrawn altogether in the coming years. This won't be money lost to the NHS. Instead, it'll be rechanneled back into overall allocations, potentially providing some of the resources needed to move under-target areas closer to their fair share of resources. In fact, this process gets underway in 26-27 with under-target areas in receipt of deficit support, having that deficit support rolled into their allocations, effectively making the support recurrent.
Okay, so that is quite a lot to take in. Are there any other changes that are needed to support the government's ambitions for health?
Yeah, sorry, it is a lot. But there is more. For a start, the government promised a shift to longer-term financial planning in its 10-year plan. It's followed through on this by issuing revenue allocations for 3 years to match its spending review settlement. It's asked organisations to develop realistic 5-year plans as part of this, as well as moving over time to a position of reserving at least 3% of annual spend for service transformation. These are great sounding proposals and likely to be supported across the NHS, but the proof will be in the eating. In theory, long-term planning might involve overspending now to deliver future savings, or incurring double running costs to set up alternative treatment pathways or invest in prevention. However, the increased focus on eliminating deficits mean it's more likely that long-term planning is about working out how to deliver financial balance this year and the next and the next, and so on. For some organisations, achieving financial balance even over 5 years will be a challenge, especially if we think in terms of eliminating underlying deficits, the bit that is currently covered by one-off savings rather than recurrent ones, and so have to be refound the next year.
Are there any levers the government can use to deliver its financial sustainability ambitions?
One thing that is clear is that the government is a big believer in financial incentives. Its 10-year plan talks about sharper incentives and moving away from block contracts, where providers are paid the same money irrespective of how many patients they see, and introducing links between payment and quality and outcomes. The planning guidance has provided some immediate examples of how this is already being put into practice. First, there is a new blended approach to paying for urgent and emergency care. While this is currently paid for using a block contract, from next year the proposal is to set a fixed payment based on planned activity times the set national price. And then a variable element will see 20% of that price added on or taken away for any activity over or under that planned level. For those that remember it, this is the old marginal rate emergency tariff on a comeback tour, albeit with a different approach to agreeing the baseline. As well as balancing risk between commissioners and providers, over time, this new or old approach is expected to re-establish the link between payment and activity levels. Current analysis suggests that the payment for urgent and emergency care is higher than would be the case if it was simply based on price times activity. The tariff consultation also started to deliver on the 10-year plan promise to expand the number of best practice tariffs. This is where a different or higher rate is paid for treatment that meets certain best practice markers. But Ms. Armani also told the HFMA conference that they should expect to see a move towards should-be costs rather than the current tariffs, which are based on average costs, or best practice tariffs.
We currently talk about best practice tariffs and we talk about average tariffs. We're going to be talking about moving away to should-be costs, particularly to enable digital change. And when you say, well, what's the difference? Should-be costs is we'll be working very closely particularly in some specific areas with clinical teams to design revised pathways that embed digital technology. And we're not going to do it too fast, but we'll work very much with the service, but this is a way we will help some of the transformation happen. And we'll start with the modern service frameworks, so just to be clear.
These could be set, for example, to reflect the costs of pathways that embed digital technology and are likely initially to be focused on the areas covered by new modern service frameworks, which are being developed to support more consistent delivery of high quality, evidence-based, digital by default care. The initial priorities for these frameworks will be cardiovascular disease, mental health, and frailty and dementia. So we should probably expect these to be the first areas to see tariffs based on should-be costs.
Haven't we been down the tariff route before?
Yes, you're right. In fact, the NHS has pulled back from tariff payment in recent years, with the pandemic seeing a major shift temporarily to block payment. But the service had already been drifting in this direction. The old payment by results system had been useful in reducing acute waiting lists, but there was a growing concern that it also reinforced a growth in hospital activity when the direction of travel was towards more care delivered in the community. We've moved back to using a PBR approach for elective activity, again with reducing waiting lists in mind. But the Labour government, I'm not sure we can really call them the new government anymore, seem committed to using tariffs to help them deliver the move from hospital to community, one of its 3 big shifts. The 10-year plan promises to introduce more widespread tariff mechanisms so that the money in the NHS follows the patient. It references both the development of year of care tariffs and tariffs for community and mental health services. All these could provide a mechanism for funding to follow patients into new settings. But it's also fair to say that we've heard this before from previous administrations with little progress. How long has the service been promising mental health tariffs, even developing a cluster currency that has now been dropped after failing to capture the clinical community's imagination? It's good to hear that work is continuing on currency models for community and mental health services, but some timescales might help focus the service's attention on establishing the key foundations of good quality cost and activity data. And apparent changes to the mental health investment standard, with spending expected to track inflation rather than the above inflation growth in overall allocations, also create some confusion around how funding flows support the government's major shifts. As an aside, Health Secretary Wes Streeting did tell the Health and Social Care Committee before Christmas that mental health services do remain a major priority, although he suggested that in future, mental health investment could be linked to outcomes rather than simply spending more and more money to buy more inputs. Perhaps more controversially, the government's 10-year plan also talked about new patient power payments, whereby patients can have an influence on whether a provider receives the full payment for treatment delivered, pushing providers to pay more attention to patient experience. While it has obvious public or voter appeal on paper, it's hard to see how it'll work in practice without creating significant bureaucracy. And other quality mechanisms, such as the Commissioning for Quality and Innovation or CQUIN scheme, have become smaller over the years, with CQUIN in fact currently paused. Incentivising quality or paying for outcomes is a great idea, but the mechanisms need to involve realistic goals, be fair, and allowances need to be made for the costs of compliance, which isn't easy in such a difficult financial environment.
So, in looking ahead, the future of NHS finance must fundamentally be aligned to the ambitions of the 10-year health plan. I don't think that any of the challenges can be solved with a span of a single financial year or a single team. The power is in this room. We've got to think about how we harness it, how we support one another. Last night there was no I'm the national team, I'm the regional team, I'm a commissioner, I'm a provider. We came together and we were an NHS finance family. I really, really hope that we can continue to work in that way and it doesn't just happen at an annual conference. I also give my commitment that, and I hope this doesn't sound trite, but your job is not to struggle alone. You've supported me in this role and you're going to have some really, really difficult choices to make. And I'm committed to backing you. I'm going to back you because we're going to have to face into those challenges.
So, in summary, the government's first set of planning guidance since its 10-year plan has taken some steps towards putting the finance framework in place to support its ambitions. But there is a lot still to come, and it'll be interesting to see how systems and providers can bring everything together in their plans for 26, 27 and the longer term.
My thanks to Steve Brown for joining this episode and helping to break down the key priorities for the year ahead and beyond. The HFMA annual conference will move to Birmingham this December with an enhanced programme, new opportunities and a reduced cost for our NHS finance community, while continuing to deliver the high-quality conference experience you expect. You can find out more and secure your place by following the link in the show notes. That's it for this episode of HFMA Talk. Thank you for listening, and if you enjoyed the show, please subscribe and leave a rating on your favourite podcast platform. We'll see you next time.